with the scientific world. So with that, over to you, ma'am.
Good afternoon to one and all. Thank you to Pallium and TIPSECO. It's been a pleasure from the time since I've been acquainted with you. So I would always thank God for all these opportunities. And good afternoon to one and all. If everyone is happy, we can go ahead with this session. And big thank you for the lovely introduction. You've concised everything to a great extent. Thank you to one and all. I'll just start sharing my screen. Can you all see?
Yes, ma'am, the screen is visible.
Okay, thank you. Good afternoon to one and all. As we have the topic for today, it's going to be an introduction to pain. In the next 30 to 40 minutes, we will see and get an overview on what is pain and how is it going to be helpful to us to understand, to treat also. Okay? First, what is pain? The definition of pain. In 1979, first an introduction was given. After that, in July 2020, the International Association for the Study of Pain have revised the definition. Mainly, they've added a few things to make sure that we understand pain also well. And it is also taken to the extent that if you understand well, you're able to treat well too. So let's see what's the definition given by them. So they had a 2-year consensus on this. They had eminent people working on it. And in July 2020, this revised definition was given. And it says, what is pain? Pain is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage, and is expanded upon by the addition of 6 important keynotes and the etymology of the word pain. So in this definition itself, we have to give importance to every word. It's an unpleasant sensory, emotional experience. So every word counts in this. That is why the importance of pain. It's just not one factor. So it has multiple factors embedded in it. That is what needs to be understood. Now we'll see what are the 6 salient features mentioned. Why have they given importance to these 6 features? First, pain is always a personal experience. So what we have to understand here is it is influenced by various degrees of biological, social, and psychological factors also, which have to be remembered. Next, pain and nociception are different. That needs to be clearly understood, which I will explain in due course of time in the next coming slides. Next, life experiences do have an important role. That is why in the definition itself, we saw it's not one thing. And next, expression of pain needs to be respected. It's a subjective feeling. So somebody else can't decide or judge what another person feels. So respecting something is very, very important. Next, pain usually is said to be to have an adaptive response, and that is why it is well known. But at the same time, we also have to understand at times it can become an adverse effect too. Last factor, verbal expression of pain is not the only way to express it. For example, in this, I would say, see, non-verbal way of expression also is possible, like tears, then grimace. And especially if you have ITU patients, they're not going to talk or tell anything. We have all our vital signs which can help us to identify the pain, whether the patient is in pain or not. So just the verbal expression is not the only mode. There are other modes also. That is what they're trying to convey here. Next, generally, pain is described in various of these things. Site of pain, where is it? How is it? Nature of pain. Extent, oh, is it from here to there? Or is it in one area? Next, are there any specific aggravating factors? Or are there any relieving factors? You have the pain. Does it go away by doing something else? And next, is this pain impinging on your routine activities? Are you able to function normally or not? So these are few things which we consider when we look into pain. Next, we are going to go into the pathophysiology of pain. On the outset, what we would see is first physiology of pain pathway is a big topic on its own, but we need to know what it is. So I've given a diagrammatic representation, and I will just take you through very important features in it, because we are going to see the pathophysiology, which is based on many of these things also. So when you consider the physiology, all of us are aware. I'm not going to, like we say, we're not going to teach granny to suck eggs. All of you know it. I'm going to give a quick bird's eye view type of thing. So at the outset, in the periphery, we have nociceptors. Nociceptors, again, can be of various types and forms, because it all depends on from where the sensory signal is going to come. So for example, in the skin, you have thermal. In the joints, you have mechanical stress receptors. And then in the visceral organs, you have mechanical distension, which is picked up. And in muscles, you have this strenuous mechanical exertion and other factors. And above all these sensory input they are rolled through the chemical mediators also. And then the information is carried through the fibers, in which you have the A delta fibers, C fibers, and then it goes to the dorsal horn. And in the dorsal horn, after the connections, then you have the crossover, and then you have the ascending pathway. And then if you take the brain as such, in the brain, many centers are involved. You have the thalamus, amygdala, hypothalamus, periaqueductal gray area, basal ganglia, cerebral cortex, everything. So that's another big thing. We will see all that in due course when we look into the pathophysiology, as I've already mentioned. Next comes the descending pathway. The descending pathway also is very, very important, because it has a role in conveying, it has a role in pain management also. So then comes again the nerve fibers, which take it to the periphery to have the implement the actual effect what is needed. So this is just a nutshell view of what physiology is. Next, we will go into the pathophysiology. Before that, as I mentioned, we very well have to understand the difference between nociception and pain. We'll see what is nociception, what is pain. Nociception is referred to as the detection of noxious stimuli by nociceptors, which is followed by other modes like transduction and transmission to the sensory nervous information from the periphery to the brain. That is nociception. What is pain? Pain refers to the product of higher brain center processing. It entails the actual unpleasant emotional and sensory experience generated from the nervous signal. So this difference has to, see, everything has its role. By one thing, what we all have to understand is we are not upgrading something or downgrading something. Everything has its role. See, without nociception, pain won't be there. So it's all interrelated. See, ultimately, all of you will also be aware, multimodal. We have to first understand what are all happening. Then we will tackle one at a time or tackle all together. That is what. So basic concept understanding is important. Next, when we go into the pathophysiology, why is this pain so different, or what is it, or why is it so? That we will see now. The mechanism by which a damaging stimulus in the body is perceived as painful by the brain, that is a complex one. What is the complexity? The complexity of the process results from the nervous system not being a hardwired system, but exhibiting plasticity that enables it to modify its function under different conditions. So that is the important thing. The two important words here are hardwired and plasticity. What is hardwired? Fixed. There's only one way to go. See, nowadays we won't be happy with that. Oh, multiple ways. I can go this way, you can go that way. Like that, the brain also has all these things. So it is not fixed. So that is the plus and minus of it. So because it is not fixed, it exhibits this plasticity, and that is why it is having so many ways and forms and presentations. Okay, so that is important. That also we will see how and why. Then pain serves the purpose to prevent tissue damage and protect the body. That is the basic function of it. Under certain conditions, pain can become maladaptive and persist as chronic pain. When pain serves no protective function but becomes pathological, it is a disease on its own. See, we have a big entity as chronic pain. It's not one thing. It exists in every field. So many. You can go into this in each, like, for example, orthopedics or gynae or any specialty you take, everyone has some element of chronic pain in it. So like that, coming to palliative care, that also has a big role. So it's just incorporating everything together. So that in one place, see, for just an injury, for you to know or to indicate some pathology, pain is a very good symptom. But at the same time, if it persists, it becomes a nuisance. So that is what we are going to say. It can be a protective symptom, or it can be a disease by its own also. Next, what is neuroplasticity? Neuroplasticity is the capacity of the nerves and neural networks in the brain to change their connections and behavior in response to new information, sensory stimulation, development, damage, or dysfunction. See, again, in all these things, every word matters. So it is not as straightforward. Like, as we said, hardwired. It is not going to respond only in one way. It can respond in so many other ways. So that is why we have all these ways of presentation and how it appears. Next comes the pain modulation mechanisms. As we have seen about neuroplasticity and things, so many things happen inside the nervous system. We will look into them like in the periphery, center, everything separately. Pain modulation mechanisms, we have described in different ways. Peripheral sensitization. What is it? First, at the site of initial injury, inflammatory mediators are released. As we saw, sensory input comes, and then that causes release of mediators and release of interleukins and prostaglandins, which further release mediators, creating inflammatory soup. So how this happens? So when the inflammatory mediators are released, and then there is some breakdown of arachidonic acid, and that causes further release. So these things are so important. So, and then when the mediators are released, they stay in that place for some time. And in that process, they can stimulate surrounding tissue also. So that is why you get an exaggerated response, and then the response stays for some time, because so the inflammatory mediator release can be aggravated also at times. So that is one of the reasons why, and the inflammatory soup makes a very important entity in pain persisting for some time, and then all the way how it represents or how it shows up to us. So next comes central sensitization. What is this? This is an increase in the excitability of the dorsal horn, so that the dorsal horn cells have a lower threshold and respond to low intensity stimuli that are not usually very painful. See, again, the dorsal, this exactly what for example, you should get a mild response. It may be an exaggerated response, or the threshold may be high. It can lower the threshold. So then it might not, normally it might not have triggered, but because the threshold is lowered, it triggers the whole pain cycle or the pain thing to be felt itself. So that is another form of sensitization which happens and results in this. Next, see, neuropathic pain is a very big element. In that, we will see the neuropathic pain arises why and how. Arises following disease or injury to nerves from a number of etiologies. See, it can be an ischemia, it can be trauma, it can be infection. So ischemia itself, if you take each one of them, we have etiology or causes for, you can have ischemia separately, trauma, infection. So that is why we see neuropathic pain in so many things. For example, diabetes is a very common thing, like all of us are aware. You have diabetic neuropathy, polyneuropathy, you can have an alcoholic polyneuropathy. So many things are possible. So for either one of them, it could be an ischemia causing all this, or it could be a trauma causing any of this. So that is why we always have to have at the back of our mind that, is there any of these happening? So could it be a neuropathic pain? So that also has to be borne in mind. We'll see the peripheral mechanisms involved in neuropathic pain. First is spontaneous ectopic discharge. What happens? So when there is at the site of injury, this again, spontaneous ectopic, every word. There may be injury to one point, but the adjacent point may discharge by itself. Spontaneous, even though the site of injury in one area, the surrounding area or the nerves can be stimulated or excited by spontaneous nature or by an ectopic discharge. So this is important, why it causes an exaggerated response or a sustained response. So this is one of the mechanism which happens. And also there could be cross-excitation of nearby sensory nerve elements. Next comes, see, this is the spontaneous and ectopic discharge is one of the important things when we see, we'll see various types of pain. In that, this is the reason why it happens. Like you have an, as I said, exaggerated response to a normal stimulus or an abnormal response to a normal stimulus. So those type of things which we will see. And this is the cause for that. Next comes altered gene expression. Altered gene expression happens through a degeneration called as Wallerian degeneration, in which the type of neurotransmitter and the level of neurotransmitters available, everything can be changed. So there can be an upregulation or a downregulation of the receptors. So which could be receptors, ion channels, the mediators, everything can be altered by that gene expression. Next, surrounding sympathetic nervous system can also get involved in this. So that is another thing which can happen. So it could have started off as just a sensory element, but sympathetic, sweating, altered temperature. See, for example, when you see chronic pain, you will see some patients will have a temperature difference if they're having more pain in, for example, right limb. If you touch the right limb and left limb and see, one limb may be cold, one limb may not be cold. So there may be temperature difference, there may be color difference. So these things are called as sympathetic symptoms. And why and how it happens? The sympathetic system adjacent to the injured sensory system can also be involved. And last is collateral sprouting, which is seen in crush injuries. So the stump pain, all those things, in that, those type of things, these will be the cause for it. Next, in the neuropathic pain element, what is central sensitization? The central mechanisms potentially involved in the generation of neuropathic pain are thought to result in neuroplastic changes in the CNS. So what is neuroplasticity? We have already seen. So under central sensitization mechanisms, we have two things. One is called as wind up and next is central sensitization. Both have the same principle underlying, but slightly they have different presentation. See, first, if you see wind up, basically wind up is an amplified response. So normally, for example, you stimulate, you should have X%, whereas it is multiplied. Like, you know, what does an amplifier do? It multiplies or exaggerates. So exactly that is what happens in wind up. If the nervous system is said to be wound up, means the amplification of the pain, whole thing, what I've explained, everything, if it was one time, it will be made into 5 times or 4 times or something like that. So similar, central sensitization is also a similar thing, but wind up is a short lasting one. Central sensitization is a long lasting one. That the concept or the basic method, how it happens, is the same in both, but one is short lived, the other one is long lasting. Here, I've just got this another important factor of gate control theory of pain, because I will explain with the diagram. See, the first one, if you see, you have the A beta fiber one side. Pardon me? Can I continue, or is there any?
No, ma'am, you may please continue.
Okay, because there was someone talking or something like that. Thank you. So see, this I will explain a little bit, because when you go into management, this is important. Like we have the descending pathway. The descending pathway can be used in the treatment of pain to help. So where you have the, if we, like for example, we all, when someone falls, we rub or rub the site of injury and get pain relief. How that happens is this is one of the concept of it. So when A beta fibers are stimulated, what happens, and when C fibers are stimulated, what happens? That is what. See, when the C fibers, first picture shows C fibers are active. A fibers, you have the cross or the red thing is there. So that when they are not in play, you have the perception of pain. So is there. Whereas when the A beta are also stimulated along with the C fibers, that is what the pain itself is not perceived. See, you see the red mark on the output. So that is what, this is the gate control theory of pain. This is the concept used in like when we rub or do something. So by large fibers stimulating that, the descending pathway, this is what happens, and then it annuls the pain. TENS also is said to work in the same way. Next, I gave you an overall view. If you see this one, the same thing, how each, how we are using the same. See, this is something like applied physiology. So like when we use local anesthetics, they work at the actual sensory where you have the receptors. And then you have local anesthetics where they work. And then you have the opioids and different sites where each method of pain management and the drugs or each one, how it works. So but that's why I said, if you understand the concept, and then we look at how we try to play in those areas to our benefit. Okay. Next comes the type of pain. What are the types of pain? Because we have so many types. Acute pain, pain that is present at the site of injury, mediated by the nociceptors, exactly like any fall injury or something like that would be an example. Chronic pain. Chronic pain is one related to pain and conditions such as diabetes mellitus, arthritis, tumor growths, etc. And then somatic pain generated by nociceptors in deep tissues, muscle, tendon, all those type of things. And visceral pain, pain in deep viscera like the gastrointestinal pain or something like that. Then you have the neuropathic pain caused by damage to nerves resulting in increased firing, which we have already seen. Then this is the next are the ones which I was trying to say. Allodynia. These are specific things which you need to understand. I will explain in a little bit of detail. Allodynia is pain resulting from a harmless stimulus. Common or well-known example, what we normally say is, see, normal touch does not cause us pain. Otherwise, we won't be handshaking or hugging people or anything like that. Okay. But if the neuropathic element is there, touch can cause pain. See, when you see patients with neuropathic pain, you will see, they would commonly say, even the touch of my dress if they have pain in, for example, take the right knee. For palliative care, we can say if they have some tumor or trauma, or some tumor in that place, or you have a secondary metastasis, anything you can take. So in that point, when that place is the point of pain, and if it is there for some time, and then the neuropathic element also is there, even their own dresses touching there, they will feel the pain. And if they themselves touch, see, sometimes they say, accidentally I moved, I went near the door or somewhere. So that normally we all go around and do things. We don't experience the pain. But when this neuropathic element is there, even normal touch can cause a harmful stimulus. And next is hyperalgesia. Slight touch or a slight thing can cause an exaggerated response. As we saw, no, increased mediators or the central sensitization, peripheral sensitization, all that, see, and neuroplasticity. What should have been, it has totally changed. So those are the reasons why this allodynia, hyperalgesia and all are happening in the first place itself. Last is referred pain, which all of us are aware. Pain referred in another area, different to the site of origin. For this, normally simple examples, I normally say two things is chest pain, myocardial infarction. Some people experience pain in the left arm. So what? It's the same nerve supply. Another common thing, nowadays we do lots of laparoscopic procedures and things. What we do, we inflate, and then we try to take the air out during the procedure at the end of, but still there may be remnant. So it can stay under the dome of the diaphragm, and they complain of pain in the shoulders. That's again referred pain. These are all common examples. Next comes assessment of pain. So we have seen so much about pain. Now next we have to see how are we going to assess it, and how are we going to, how is the assessment going to help us? See, we are doing all this to help us to treat the patient. That's the ultimate goal. One and only thing. We always do everything in the patient's best interest. What is that I can do to help my patient? That is the thing, isn't it? That's our aim, goal, everything. So it is said that assessment of pain has a role both in knowing and studying about pain and also in pain management. So it is very, very essential and important. And acute and chronic pain assessment has to be done on its own entirety, because we have seen there are two types. So everything has like one size fits all doesn't work, isn't it? We are also made differently. So similarly, pain also we have seen now that, oh, this has separate features, that has separate features. So we should deal with each one of them separately. So for the acute pain, you have the normal numeral rating scale, visual analog scale, the dynamic pain assessment is there. See, the dynamic pain assessment is very important. See, sometimes, oh, I don't do anything, I'm fine. Once I start doing, I can't do anything. I just can't even move out. So in that case, what is the point? Oh, if you sit, but that's not how everyone wants to have a better quality of life. So that's why every element is important. And then baseline pain assessment is always important. And with pain, again and again, reviewing every time is important. That again has two roles. One, whether the pain has itself could have changed. Or, and next is whether whatever method of management or thing that you have advised to the patient, has it benefited? Or I've given no response, I just carry on. What's the benefit? No benefit for the patient, no benefit for me too. So that is why reviewing this assessment regularly is very, very important. I can put how many ever berries to it. Okay. Next, chronic pain. Chronic pain, because we have seen it is multimodal, multidimensional. So it has multidimensional qualitative tools. And there are many tools for particularly each specific disease, patient types, like dementia patient, elderly patient. So these are all, it's an array of stuff is there. And that I would say it is entirely tailor-made to your requirement. So there's no one rule, all should follow one scale only. There's nothing like that. Some basic scales are there, and then you tailor-make it to your area of practice. See, I should have something which is user-friendly. No point I have something which neither I am comfortable with it or nor the patient is comfortable with it. So with chronic pain like that, many things, you use what is best to your area of practice. And also a regional thing you have to see. So, and you can also incorporate many more things. Many places will also have HAT score and things, which is, see, when chronic pain is there, you have to think the other element, emotional, social, psychological. Is there any depression element in it? So there are so many incorporated scales and things available, scales and scores. So you use what is best to your area of practice, and everything, even you pick up any scale or rating that you like, you can do translations, forward, backward translations. And then see all this, how I'm able to say is, having worked in Adyar Cancer Institute, I have used some quality of life assessment scales and scores. And we did a forward and backward translation. And if they both, see what that means is, you pick up any scale, you translate it, and then you do, that is forward translation. When you do backward translation, you should get the response in the backward translation to be ideal to match with the original form what you've used. So that justifies. So you can pick up anything, do all this, and make something which is good to use in your place of practice. So that is all it is. So I've just given few ideas of what are all there. See, the numerical rating scales. See, nowadays, I think many people are aware. You can tell them if 0 is no pain and 10 is maximum pain, where would you say? And then some you can say in number, or you can say in words. So, and those are the things how I've represented there. In that itself, you have like through facial expression. So some people, because see, language barriers, educational barriers, demographic differences, so many things are there. So we have to put everything into perspective. So no, some people say, no, I can explain by words. Okay, fine. So some say I can explain by numbers. So you go to what is best for the patient. And next, this one, what I've represented is a common thing, because sometimes they may not be able to say. We have these charts in which you can ask them to mark, or you tell where all is your pain there. And so that from where to where, which site, all that can be given. And then you can use the same scale, as I said in reviews. Or is it still there, as you said to me before, or has it changed? Has it moved? Or has it got better? It was in a wider area. No, now it is only to one point. So all that, everything helps you. So there are very many ways how it can be used. And each place has a very good mode of representation. And for the chronic, you have the basic pain inventory, and you have the Meggle pain questionnaire. See, these are all, again, as I said, they will have a little bit more in detail. They will say the types of pain, and then in each type of pain, you can grade that, mild, moderate, severe. So what you're trying to do is, you're bringing in the expression element, experience element to it, and then the degree also in it. So those are the things. And then you can add the quality of life questionnaires also too, because see, as I said, no, is it impacting your day-to-day living? Because normally we used to have, like, you can have in the last 7 days, what has this pain cost you? Has it made you not been able to do anything? Or were you able to do some, like we have pain diaries, you have many, many things in this. So as the need, and then first is need, then what type of patient, then what time you have to have everything in perspective. You can't sit with one patient all the time when you have 50 patients to be seen. So you have to make a balanced assessment of what is needed, what can be done, and some questionnaires can be given to them and they're waiting for them to fill. So when they come to you, you have everything in hand, so you do it. So there are so many ways and means how it can be done. Next comes cancer pain assessment. See, the major impact on cancer-related pain management happened after WHO guidelines of 1986, but still globally, relief of cancer pain is far from satisfactory. They say one of the main reasons is non-availability of analgesic drugs in many places. So that is still a big issue. People are trying and deal with it as much as possible. And concerning palliative pain management in palliative care, all what I have said, you have to remember. And on top of that, you have these things very, very important. I have enlisted them here because, see, pain itself could be an important thing. That is what is restricting me from doing anything. So because of that activity, because of the pain and activity restrictions, maybe from doing everything to a zero state, they can come down to 360-degree turn type of thing can happen. And then you have underlying other factors, nausea, vomiting, depression, because see, palliative care is something all through your life, you don't think of this one entity at all. And it can come all as a surprise. And so, because see, no one is prepared, none of us are prepared for anything. And then something like palliative care element comes in, your depression may come to the top of the list than anything else. So depression and anxiety, they are like a vicious circle. They can go round and round. And then loss, as I said, loss of appetite is a common thing. They may not even understand. So if you explain, or loss of appetite could be a symptom. So how, in spite of that, you may have to eat in small quantities. So teaching them awareness and all these things are important. General well-being may totally be shattered because see, loss of appetite, no intake, no activity, you're only in pain and you're depressed. Then how is your well-being going to be? So, and then last but not the least, is shortness of breath can be due to very many factors. So that is why when you think of having a patient with palliative care and palliative care, pain in palliative care management, you have to have all these also in mind. So for that, you have some specific pain assessment tools and inventories available. And as I said, in that also you can have disease specific, as I said, for dementia, for elderly, for children. So you can have many, many of these. I can go on enlisting, but it's just to be aware of, that's all. Last, one thing what I would love to say is, see, always a thing of beauty is a joy forever. What is it said? So in that, why do we say that? Because see, something nice or beautiful stays for long. That's what is being conveyed in that. So it has an impression on you, which stays for long. So that is why, see, chronic pain may be a difficult issue, but because it has the emotional, psychological elements in it, that is where we are trying to use pain management. That element is used in pain management. So you can have or add on, see, you may have an unpleasant experience, but you can see how can you change the unpleasant experience to a, maybe not a completely pleasant, to a state or a better state. So that is where we have to use all this. And so this does play a role in the management element also. So that is what has to be borne in mind. So multimodal management is what to be understood, because there are some things, plasticity or neuroplasticity, which cannot be changed, but psychological, social element can be changed. Here we can use these SMART goals, something other. What are they? Instead of having unachievable goals, you have small, measurable, achievable goals, which can be reproduced. So, and that is what has to be taught to the patient. So rather than aiming for something impossible, try for something possible and at small level, small state, and then move forward. And when you're able to do, you yourself, the patient themselves will gain experience and confidence. For example, with palliative care patient, they may not be able to do any big scale exercise. You can teach them chair exercise, just sit, stand. Nothing more than that is needed, because they can't do anything. We have to put ourselves in their shoes and see what is best for them. So in that point of view, I would say that simple, it's a very, very important thing which I said, just sit, stand exercises, chair exercises. So that will make them think, oh, is there a way like this? So I thought only if I'm fully mobile, I can do. No, there's nothing like that. Where there's a will, there is a way. So this is what our aim and goal is, to help them, as I said from the beginning. So you have to use the knowledge to help you to manage. Okay. Thank you, one and all.
Thank you so much, ma'am, for that presentation. It was as concise as one can put and talk about pain. So pain is, as we all know, it's an iceberg. It's like an iceberg phenomena where when a patient says that he has pain, what seems obvious to us is only the tip of the iceberg. And once we start exploring it, it may take multiple sessions even, but once we start exploring the various dimensions of it, then we start seeing beyond the physical, that is beyond the immediate disease process, which is diagnosed. But apart from that, there may be many reasons like psychosocial, psychological, emotional, even spiritual reasons, which will have an impact. Ma'am, if you would like to comment. Yeah.
The spiritual, what you have said, we did even a study when I was in Cancer Institute, Adya. There is very great evidence in that, especially in palliative care. If a patient has some element of spiritual concept in them, they have found they deal with the whole palliative care entity itself in a better way. So that is where this quality of life, we did a quality of life questionnaire and did a study for a short time also. So it has so many components to it. And many times you may think this chronic pain, if you sit and talk with the patient, you will find the social and psychological element. Once they gain rapport with you, everything unravels. So what was very complicated might become very, very easy, simple issue. They would have thought, oh, I was not happy to say, oh, you have given me the opportunity to open. So what they might have thought difficult, we might have thought difficult, will all be solved in no time. So when that is so important, so that is why giving some time, having all this, just not thinking it has got one element, injury, that's all. No, it has got so many. That's why nowadays many places have a combined setup. And again, it is all resource based. You can have a pain physician, can have a psychologist and a physiotherapist. Normally, when you have any program or something like that, you have all of them in one place, seeing a patient. Or you can combine like 30, 40 patients together and have them in one group. And especially when you do that, the patients themselves, your job is reduced. They will start talking. I thought it's only me suffering. Is it there for everyone? And the whole problem gets solved. So there are so many things like that. You can have group programs, you can have group sessions, you can just have group sessions for them. See, that's all. It's done in very many ways. And as you said, it's only the tip of the iceberg. Big thing is underlying. So it has to be taken, and not that it cannot be done or anything like that. Once you understand the concept, then you deal with it accordingly. That is.
Thank you so much, ma'am, for taking it forward that way. We have a question for you on the chat, ma'am. It's from Dr. Kanmani, who's asking how to assess pain in an unconscious patient.
Okay. See, as I was mentioning, see, for example, if you have patients in ICU, very many things are there. I'll go step by step. Vital parameters, heart rate, blood pressure, everything. All of us know that. What is the normal heart rate, blood pressure, and if someone is in pain, it will be exaggerated. And then you have all vitals are leading factors for identification. Blood pressure, basic is blood pressure and heart rate will be high. and you have the patients unconscious, they may have tears, like when you squeeze or do something. And tears is one of the common thing, grimace, even intubated patients can show all these things. See, being an anesthetist, I've worked in intensive care all my life. So these are all very, very simple things which can be picked up. All vital signs are an indicator. Pain is the 5th vital sign. So that's another thing.
Thank you, ma'am.
Is there anything else in the chat?
Not in the chat box, ma'am. If anyone of
If
you
anybody,
would like to unmute yourself,
wants to ask, unmute yourself and ask.
You may please feel free to do so. You may even raise your hand and we'll give you a turn.
Yes, raise your hand, will come on the top of the screen.
Hello.
Yes.
Yes, Dr.
Yes,
Pratiksha, please go ahead.
Yes. Ma'am, in pediatric patients, it is usually a bit difficult. We can understand that they are having pain, but to assess the degree of pain is usually difficult. So would you suggest something we can use in them?
For assessment?
Yes, ma'am.
See, assessment with pediatric patients is not an easy thing only. Okay. See, that is where we use this facial grimace type of thing. And again, in pediatric patients, you have different age groups, isn't it? See, for example, under 5, after 5, no, whereas when I have seen patients after 5, under 5 is a bit of a, it's like in that case, you get the rapport with the parent. And see, if for under 5, you use the child and the parent. Whereas for above 5 children are much better off. And then you can see what is it. You can talk to them and ask them what they're able to do comfortably, what they're not able to do. Because from 5+, I have seen children, especially when I was in Cancer Institute, I have used, and then we have even used morphine, and then they are able to communicate to us. 5+ is okay. But under 5 is a thing where you may have to get the rapport with the mother or father with whom the child is comfortable. Okay. So with that, see, you can say the child refuses, like as human beings, we have so many things. We have to be very alert. See, for example, the child will avoid using that right hand, I'm telling, right? They'll slowly start doing everything with the left. The mother would have picked up. Oh, he wasn't like that before, but I've noticed that he's doing this in a different way. So like that, you can see they'll have habit changes.
Yes. Okay.
So, and then habit, then food, everything. As I said, the psychological, all these elements will be there. So that is what under 5 is. It's the rapport with which we, and for example, sometimes we normally say, isn't it? You have the child on the mother's lap and examine or talk to them or do something, you will get a better response. Fear, everything is gone. So they'll be themselves. So everything matters. So those are the things. 5+, from what I've seen, from 5+ to 15, they are okay if you talk to them, because 7 and 8-year-olds also, we tell them how to do and things, and then tell them if, for example, if they have some tumor and all, movement and things will be difficult. So when we teach them some things, and then you see if that is benefiting them. So 5+ is different and under 5 is different. So it has to be looked into more of how that can be done. And then the help of the parent does play a bigger role. And we have to look into everything. We can, as you said, we have to look into, as I said, get the history from the parent and then observe the child when you're examining itself. That will throw so much of information for us.
Thank you so much, ma'am.
Welcome.
Thank you so much, ma'am. We'll just wait for another minute if there is another question coming up. Please feel free to raise your hand, or you can directly unmute yourself and ask ma'am whatever query you may have. Ma'am, in the meanwhile, we'll just have the slides ready for the case presentation, which is coming up next. Dr. Akanksha, are you ready for the presentation?
Hello. Good evening, everyone. Can you hear me?
Yes, ma'am. Yes, ma'am. Just a moment. Ma'am, shall we proceed with the case presentation?
Yes, yes,
And
yes, yes, yes. Go ahead.
discussion after it? Sure, sure. Dr. Akanksha, you may please continue.
Okay. Good afternoon, everyone. I'm going to present the case, and thank you, ma'am, for the wonderful presentation. Now, the case is all about a 56-year-old female patient who has carcinoma gallbladder, and it is a locally advanced disease. The presenting complaints are she presented to the pain clinic with gradually increasing pain abdomen, which was radiating to back, and it was associated with vomiting. Also, she complained of persistent vomiting, which was not controlled by antiemetic drugs. And also, there was complaint of loss of appetite and dyspepsia. Patient presented to pain clinic OPD in May with chief complaints of pain abdomen, which was more in the right hypochondrial region, and it was radiating to back. Pain was severe, and numeric rating scale was 9, and it lasted whole day. The pain was uncontrolled by weak opioids and NSAIDs, and there was less than 10% relief with tablet tramadol, 50 mg TDS, and tablet paracetamol 500 mg QID. On examination, patient was found to have pallor. Per abdomen examination revealed an ill-defined mass in right hypochondrium region, and it was tender to touch, and it was restricted on movement. On digital rectal examination, no mass or growth was felt. A surgical gastroenterology referral was sent to evaluate the disease status and help plan further management, who, upon reviewing the case, advised for CECT, abdomen, and ultrasound guided biopsy of the gallbladder mass. The investigations were done, complete hemogram was done for pallor, and LFTs and KFTs were done to determine the derangement of liver functions or to know the dose modification requirements in case there is an impaired function. CCT abdomen and pelvis was done to look for the disease status, and then the levels of CEA were done so that the baseline levels could be noted, and ultrasound guided FNAC of the gallbladder mass was done. Now, one of the aspects of the pain were the physical pain, and other was the psychosocial aspect. The patient was looking depressed and sad, and she talked very little. Most of the day, she was lying on the bed and no activity. And on interaction with the patient and family, we came to know that patient has been fearing death. She feels that the pain and suffering will increase with the time. Also, she feels that she's a burden on her family, and they have already spent too much on her illness. Then we counseled her that we will take care of her pain and will do whatever possible to make her feel better. We told her that she may be hopeless, but she can try to stay happy and live one day at a time. We spoke to her family and explained to them that they should take care of her and she should not feel disowned and lonely. As the medications, we reviewed medications, she was in severe pain and not getting relief with weak opioids. We started oral morphine, supportive management, and we planned for select plexus neurolysis. On first presentation, when she was in severe pain, we administered her 5 mg 4-hourly morphine, and also for the breakthrough pain, and also paracetamol, 650 mg QID was added. After 2 days, the morphine dose was increased to 10 mg 4-hourly, and also tablet amitriptyline was added as an adjuvant. Once she was relieved with pain, we worked up in detail, and we assured her that we will take care of her pain and she will feel better. Also, for vomiting, we added tablet dexamethasone OD for 7 days, followed by tapering over next 2 weeks, and tablet Amset and tablet Perinom were continued. Now, the main concern of the patient was pain. Other concern was vomiting, and another major concern was worry about the financial burden of her illness to her family. So I would like to summarize the case, as she's a 56-year-old female diagnosed with carcinoma gallbladder, locally advanced disease, presenting to pain and palliative care clinic with gradually increasing pain abdomen, radiating to back associated with vomiting. Now the patient was given a multidisciplinary holistic approach for management. She was started on chemotherapy and she was taken on oral morphine, which was titrated for her pain. Both these measures helped control her pain, and along with the physical aspect, we tried to take care of the psychological and spiritual aspect by counseling. So we would like to discuss the following points based on the patient's story: physical care for pain and vomiting, then social care, spiritual care, and communication with the patient and family, which is very important, and any ethical issues we as a doctor we encounter while giving palliative care to these kind of patients. Thank you.
Thank you, ma'am, for that presentation. So as we can see here, there are many aspects to this patient. Shall we go into it one by one? So one of the primary principles of palliative care is correcting the correctable. I would like to put out this question out to the group. I want a little more active participation. What do you think are the things which can be corrected over here, or we should make an attempt to correct, so that the symptoms of this patient, primarily pain, can be controlled? Yes, Dr. Vandana, please unmute yourself.
Yeah, I think we have already discussed the various very important emotional component. Component is that the patient feels that she's a burden. So this feeling that the patient has should be taken care of. It primarily rests with the relatives.
Right. So you're of the opinion that the emotional component of the patient has to be addressed. Right. Definitely, yes. So Dr. Haripriya says that counseling and communication with the patient. Yes. So Dr. Akanksha, is the patient aware of the diagnosis per se, or is she just knowing that she is sick and her family members are getting burdened by the treatment?
Actually, initially, she didn't know, but on subsequent visits to the clinic, we discussed with the relatives that she should know, and we explained to her that the diagnosis we explained to her, because initially, when presented to the first time, she was not aware.
Right. And how many sessions did you take to do this, or was it in a one-shot session?
Well, in the second visit, we discussed it with the patient because she was already very depressed, and it was we think that it is needed to tell the patient, because otherwise they are very confused that what is happening, and because somehow they get the sense that something is not right, but they are not sure, so it kind of creates restlessness and they are not able to plan their things. So I think in one attempt, we told her.
Right. So looking at the site of the illness, which is the gallbladder, and you have said that it's a locally advanced disease. The patient is also having vomiting. Is there any other possibility which we should consider clinically? Others also, please feel free to use the chat box. Some of you are using the chat box, or you may raise your hand as well. So a person who is having illness or a tumor in the gallbladder with a locally advanced disease, having pain as well as vomiting. Yes, Dr. Mohammed Sajid, please unmute yourself.
Good afternoon. So I think there are two issues to this. One is the psychological aspects, describing things to the patient. Perhaps that is one aspect. The second part, which actually worries me, is that how far we should go in terms of treating her problems or finding out solutions for her real problem related to the malignancy, whether related to the vomiting, because there are some interventions that might make things a bit difficult for us, say for example chemotherapy or pain. So have we completely left out those treatment modalities, saying that we cannot do anything more than that? This is the point that came to my mind.
Right. Sir, you said that there are some, if we take certain routes, it may become difficult for the patient. Do you have anything specific in mind?
Now, say for example, I would like to get an oncology opinion related to what their plan of treatment at present related to this specific stage of disease. Is it worth giving? Is it a futile exercise to give chemotherapy? What is the benefit of giving chemotherapy? Pain is one thing, yes, that can be treated by pain clinic. Vomiting is another issue, because vomiting itself with drugs, how long it will be controlled? Should we need to do any other interventions? Would it create difficulties for the patient? So that actually is a point that we have to clarify. By doing more, will we harm the patient? So for that purpose, I think the counseling needs to be done in a stepwise manner, in a gradual manner, explaining things to the patient, giving them all the aspects of management, meanwhile getting an oncology opinion and going for a shared decision making.
Thank you, sir. That's a brilliant approach. Ma'am, you have unmuted yourself. Would you like to
Yes,
add?
that's what I was just waiting for people to talk, so that, see, basically having heard discussion points in front, I'm just going to tell you what will be the best, one of the best ways. There's no one thing only. They can be. So always in these type of patients, first a multimodal management or an MDT, which is done everywhere. First an MDT approach. So you consider everything. Pain and palliative care alone cannot exist, and that will not give a, see, even when you see a patient, you have to see patient head to foot. This one point that, so I'm just going to deal with the pain, that will not work at all. So first MDT. So everything has to be done in a methodical way. First you get an MDT, where exactly correct the correctable. So there we know what stage, what all possible MDT. So you have a medical, surgical, all, what all can be done, what cannot be done. So that has to be considered first. Next comes, you have to proper discussion with the patient and family. And that may not be possible in one or two sitting, as you said. And we have to use the spikes protocol to convey the information. First, we have to know what the patient knows, what the patient does not know, and where are they ready to take. See, phase of denial is very, very important to be understood, re-understood, understood so many times, because you may be seeing the patient n number of times also they may be in denial. So first, we have to find out what they know and what they need to know. And then if they don't know anything, we have to take time, explain to them. That is why I normally say, in your running schedule of seeing patients, you may not be able to. So these type of patients, you have to tell them to wait or come in a time, and you have to give some time. And then either patient, next of kin, or whomever they want to be, with some minimum people, you talk to them, explain. And sometimes when you explain, they have fears and things, like they would have imagined some things. And always everything what is said or written down in any book is not going to happen to every patient. That has to be conveyed to patient. So everyone fears, oh, I will struggle more only before it. There's nothing like that. Because so many patients I've seen, see, I keep telling this again and again, not necessary everyone is going to struggle only. It's not like that. When you start patients on morphine, I'll give you one or two examples which I've seen. I've seen a 60 a lady who was actively working, diagnosed with stage 3, stage 4 CL lung. She was not getting good pain relief at all, so she stopped working. Then I got to see her. We started her on morphine, and she decided that she's not going to work, but she started staying at home. She was able to do everything. She even started cooking, doing everything. And then she was on, like, started off on 5 milligram, went up to 10 milligrams. She settled with that. They were contemplating on giving chemo again, yes, no. Then the family decided, oh, no, because when they spoke to the team for chemo, they said, explain everything, and they said she's not going to have the second, another set of chemo. And about 3 weeks or something, she got up that morning doing everything, and like midday or something, she died at home without any issues. So not that. So we have to give some confidence to the patient, not that everyone is only going to struggle. So all these are important. So MDT, then seeing, explaining, awareness and knowledge, what is needed for them. Then comes pain and vomiting and all, especially GI system will have a lot of vomiting as symptom. So in that, you have to try different medication, and few things we have to tell them. These antiemetics have to be taken on empty stomach. They have to have it at 5 in the morning. See, these all, some of you may think, oh, this is very simple, I don't have time to. It is not like that, dears. It is, everything is important. Patient might not have known. So I used to sit and tell them, like, see, for example, you take the antiemetic first thing in the morning and give 45 minutes to an hour before you start to have anything else. And you do that for 3 to 4. Even when I start them on morphine, I will explain this, because if they don't do that properly, morphine itself has causes vomiting to a great extent, and they won't take the morphine itself. They will end up skipping that, because that can cause vomiting. So if you give the antiemetic before and tell them they have to have that 45 minutes before the morphine when they start. So the medications for vomiting is important. And then adding dexamethasone as a medication for vomiting does wonders. Even IV, like sometimes if they're very sick in the hospital, IV dex will do the trick. All this I'm telling, as I said, I've been an anesthetist. Anesthesia, vomiting is a very big issue for us. So that vomiting, and then next especially with gallbladder, liver, pancreas, this thing, what normally say, like 4-limb position. All of us have learned when we did medicine. I am not teaching anything new. Ask the patient to go on their 4s. That is like a child crawls. Use this presentation had everything like textbook, like pain radiating from front to back, retroperitoneal, like all. So these type of things, especially when you tell them to do these type of things. Sometimes, see, I'm not telling this is like a magic wand, but if you teach them to do these things, that can help. So every little things what you can do. Then comes psychological, social, and all. See, some things, financial element, you can treat, you can't deal with anything and every financial element. So we can talk to them and say, this is what it is. So once you have a proper MDT, you will know how far you can go, and you can explain to them pros and cons, and then they make the decision. See, we don't make the decision for them, but we only help them to make the decision. That has to be very clear. So there the social, psychological, financial element, and then patient not being a burden has to be taught. See, always, I say this like a parent-child, like when we are children, our parents forego so many things to do for us. See, we can explain to people who are willing to listen and understand. That's all. We can't do social service element also, but it's our duty to do that also. So it's a give and take. When we were children, our parents could have kicked us and gone. So they didn't do that to us. So it is our duty. It's all humanness is there. If the humanness is already there, or the spiritual element is there, this humanness element, they are all intertwined. So that will help you in a few things. And communication to the patient and family, that is very important. Sometimes they may be a close-knit family. You will know all this when you get the patient. You don't need to ask them at all. Everything, like as I said, non-verbal form for pain. We have non-verbal communication, so many things, body language, how they say, how they react, everything will get, we have to have our eyes, ears, everything sharp to pick up everything. And ethical issues and all is based on what is important. See, our job, as you said, palliative care, we'll correct the correctables, we will not do any harm. We have to make sure that we don't do any harm. At the same time, we have to do what is possible for the patient. So every element of it, we have to incorporate all essential aims of palliative care along with the pain management, patient management, everything together. And MDT is very, very important. If you don't know what can be done, see, sometimes, okay, we can't do any curative management, some palliative radiation, palliative, all that is possible. Okay, then we will go explain to them in that way. Are you happy to have that? So that would be a better way forward. What doctor gave, I have picked up with that, compiled everything, and I thought this is one way to take it. I'm open to discussion, whatever others feel also.
Thank you so much, ma'am. That would be the most ideal way to approach any case for that matter. From the perspective of some of the participants, I'm just going to read out some of the chat box responses we have received. Dr. Sharon, yes, an upper GI or gastric obstruction due to compression by the primary or secondary nodes can induce vomiting. Definitely, we have to think of an element of obstruction which may be present in this patient. Dr. Akanksha, did this patient also have a constipation, or was there any GI findings on auscultation like hyperperistaltic bowel sounds, something like that, which points towards a bowel obstruction?
Actually, no, patient didn't had much of symptoms of GI obstruction, mainly maybe due to the severe pain. The patient is having vomiting as well. It was not much clear to me that why the patient was having so much of vomiting.
Right. It is true. A patient having a pain scale of 9 on 10 in the GI location, major area having the liver, gallbladder, the duodenal, different parts of the duodenum around it as well. Possible. Ma'am, you have any suggestions on that? Any thoughts on that?
Is it just why? What is the reason for the increased presentation of vomiting? Is that your question?
Yes, ma'am. I think that is what needs to be discussed.
See, vomiting, no, like I would say the pathology, see, bile is very common cause. It itself, so being gallbladder and the site of it itself can be one of the important cause for the pain being one of the symptoms. And then here the patient was on morphine, and we have to literally ask, are they taking the antiemetics properly? See, see, all these may be little things, because they'll say, doctor told me this is pain, I will take that. Oh, that was vomiting. So that and all, no, like we have to sit and talk to them and find out if they are taking properly. And managing vomiting is a common issue with all these things. So that is why, even though you don't do polypharmacy, but you have to change. You have to try other, sometimes you wouldn't have tried metoclopramide. So that might work. So you have to change and see what works. and asking them to take prior to anything else they have, and adding DEXA on and off will help. See, sometimes you need not add DEXA continuously, because then you have like steroid, all those elements also. You can use short term, like 2 days, then you can start rather than using for longer time. So if it is inpatient, IV DEXA 1 dose or 2 dose will do the job. So those elements are there, and trialing medications, and then especially gallbladder and things do have a high incidence of vomiting.
Thank you, ma'am. Following up that response on DEXA, ma'am, we have a question from Dr. Rishikesh. She's asking, when should we consider DEXA for vomiting management? Is there any specific sequence, like a failure of antiemetics, or should we concomitantly use it along with opioids? How to approach this?
No, normally you do only when you have difficulty in managing. See, we won't add DEXA always as first choice. Like, for example, you have tried one or two medications and still it's not helping. Inpatient means I would try straight away. Inpatient, first, second medication, no response, I would straight away go and try, because when you have them as an inpatient, it's better to give IV dose and then manage it easily. As I said, even 1 or 2 dose will do the job. Whereas if it is an outpatient you have, then you can try a couple of medications, and then if not, try it.
Thank you, ma'am.
That's all. You would not go on trying everything and then try, because anything, preemptive will say, if someone gets really up on it with that symptom and they get annoyed and upset, that's not nice. We have to think of the patient, be in their shoes also. As long as you're hale and healthy, that is why it is said, health is wealth. Whatever wealth you have when you're unhealthy, that doesn't help you in any way or form. So we should not allow someone to carry on struggling for long. So that will have so much of impact on psychological, emotional elements in it.
Thank you, ma'am. We have a question from Dr. Kanmani. She's asking, is there a maximum dose limit per day for morphine and dexamethasone?
No. Like, see, morphine, actually, you go titrated to the pain control. That's all. So morphine and all, it all depends on the weight of the patient, milligrams per kilogram body weight. And then normally, if you start with 5 milligram, by 10 milligram 4th hourly, something, they start to get good response. And then again, availability, you can go on, if you stabilize them on something, you can add long-acting ones. And one more thing I wanted to tell in the discussion itself, which just came up to my mind. See, they added adjuvant, but like, see, you have to see either amitriptyline, or if you want to add gabapentin. See, because gabapentin does do a better role than, not that, see, there's no hard and fast with this. So you have to try some adjuvants also. You have to have the morphine and the adjuvant together. Because as I said, we had so much discussion on neuropathic pain. So when you add the adjuvant, the morphine dose need not be increased. So the role of adjuvant is very, very important. So even if you see the WHO ladder, what does it say? Step by step you go. So once you see no response from mild opioids, you go to morphine. When you go to morphine and you add the adjuvant together, the adjuvant will definitely help you not to keep on increasing the morphine. So that is why. So for this question for dose exactly for morphine, you see the patient. See, if the patient is normally like 50, 60 kilos patient, means like 10 milligrams, 20 milligrams. And see, sometimes if the disease is very advanced, then you need. So in those situations, what you have to do, you have to have the morphine, you have to have the adjuvant, and maybe you add the paracetamol also in between. And you have a schedule that Like for example, 6 o'clock, they'll have the morphine. 8 o'clock, they will have the adjuvant. And then, so like that, round the clock, they will have. So, you know, next little bit of pharmacology. You have to have a baseline level in the blood. You don't have peaks and troughs. So if you have peaks and troughs, whenever the patient is having a trough level, it will have a, we don't want that. We want them to have a somewhat steady state. So all what you have studied from first year to final year of medicine has to be in our blood on our everyday practice. So these are all simple things. All of you know everything. I am talking from all what I did through my years only. So, and I always say our basic 5 years comes with us all along. So everything has a role. So like that, you have to make sure that all elements are there. So that is what for morphine also, it is, if you combine these drugs together and all, your need to increase the morphine will not be there. And then DEXA and all is given only for short time, and the vomiting symptom does subside. As I said, sometimes the ondansetron, either, as I said, you have to try everything. Don't think, oh, only ondansetron, because we are all not alike. We are all different for different reasons, and we have to take it in a good way. So in that case, so you thought this would work. Okay, change to something else and see, then that might work. Okay, that is what would be a better way forward. And for DEXA, there's no specific like this much, something like that. You use it and then you get a good response. If you're using it for like 1 or 2 doses, you can stop it. Or if you're going to use it for 5 days, 7 days, then you taper and stop. Is availability of DEXA, because the availability of DEXA on and off, is there, not available? How is it? Because, hello?
Yes, ma'am, please.
Because no availability of DEXA, because in between short time there was non-availability of dexamethasone. Is it easily available?
It is very much easily available, ma'am.
Oh, then fine. Because in Chennai we did have some little bit of 2017, 18, I think. That time it was not there. So then afterwards we used to have in some places. So that is why I wanted to ask.
Sure, ma'am. Thank you so much, ma'am. Following up on concerns with respect to use of morphine, Dr. Samiran is asking, morphine causing constipation, how do we find the right balance?
With morphine, constipation and vomiting are like hand in hand. So for constipation, you have to add cremafin, you have to add laxative along with that, and also advise them on fibrous food. That's also, see, everything is important. One method or one way alone won't work. So we have to use our common sense. Constipation and morphine is a well-known thing, and you add the laxative. Again, laxative also, you can tell them to take it regularly, not when leave for 4 days, 5 days, and then when they're having the constipation, trying that will not work. So these have to be told that it has to be done on a regular basis. And then in that also, you have to try few options and see. Cremafin normally works, but if you think cremafin is not okay for them, then you go on to like tablets, or you give liquid forms. You have to try all options, and you have to advise them to drink plenty of water, fibrous food, everything you have to say. And main thing, especially with palliative care, is their intake is so low. Okay, when intake itself is so low, then constipation, you end up even have to do evacuation type of thing, because intake is low, they are immobile. So these are issues which do come up. So these are all things you have to, like suppositories or various type of things you have to have in mind. For morphine, only thing is that you have to advise them to take it regularly. The day they start morphine, they have to have it, so that it doesn't become a big issue. But see, again, you have many other medications also, but again, everything non-availability also you have to have in mind. So regularly taking that is one of the important, simple things to be told, along with other common stuff that I said.
Thank you, ma'am. So just a field perspective, Dr. Samiran, we do start morphine for patients at their home. And when we do that, we start them immediately, like ma'am said, for the initial few days on an antiemetic like metoclopramide. And at the same time, we'll start them on a stool softener. And once we have finished using metoclopramide for the first 3 to 5 days, then we start them on tablet bisacodyl, which is a stimulant. So a stool softener plus a stimulant is a standard combination which we use, and we teach the caregivers to titrate the doses according as per requirement, because there may be days when it is the constipation is more. There may be days they may tend to have loose stools. So this is a balance which they have to find, and we have to empower them that this is not like a dangerous drug, but this is how you are supposed to titrate it, and they themselves learn to in a few days, of course, to learn to manage the situation.
Exactly true. That is where I was also coming to. Good that you said, because I will always, you have to tell them, golden statement you gave. You have to tell them, and you not blindly, just as I said, then they will end up having diarrhea also. That time they have to bring it down. And sometimes normally we say once. So, okay, they've not opened their bowels. You can take it 2 or 3 times, depending on the need. Increase, decrease, tailor make it, or need based. So exactly what you have said is the golden way of management. So you have to teach them, and then they have to use their perspective. One day they might not have had anything. So then next day they might have had a couple of drinks or something. So like that you have to do. And then one question was there about nutrition. I think for this patient only in the chat box, I just saw. So basically,
like you said about intake, yeah. So how can we address the intake?
So see that again, normally what you have to tell is, as I said, you have to tell them to take the tablet before having any food. Give 45 minutes to an hour. Next, you don't have one full gulp or one full 300 ml in one go. You never do that at all. Especially because when they are so sick and like that, just like 100 ml, you give that 100 ml few times, but that 100 ml should not be some watery stuff. You give some nutritive, full of protein type of thing, that half 100 ml you can give every hour. So what goes in is important. So that is where this Ensure or homemade, like everywhere they make this kanji with all, see, I'm not someone going always for high-end stuff. You have best in your hands. God has given you so much of ability and capacity to do. So you can make just homemade some all vegetable with lentil soup or bone soup. I will tell them whatever works for you, because that is what they would have been used to. If you give them something from outside which doesn't taste at all, they won't like it. And already their appetite is so low. So give small quantity, frequent meals. That is the cornerstone for palliative care, food supplementation, energy requirement. So small quantity, frequent, hourly, once in 2 hours, something. But that 100 ml should have full, all caloric, protein, nutritional, all element has to be in that. So there you have to make sure it is done that way. So that's where the role of family comes. So what we can do, we can tell them, oh, you don't feel bad. You do something like this and get. So their relationship will improve. So we have to see and do what best, and then what is good for them. And by doing these type of things, the social and family issues will all come down. So small quantity, frequent, nutritive meals.
Thank you so much, ma'am. So I think with that, we have come an end to the questions as well. We have crossed 4:30. Ma'am, any closing remarks from your end? Ma'am, you're muted, ma'am.
Okay. The doctors from which areas or regions are they?
And we have doctors joining in from all parts of India. Majority Keralites are there, and then we have foreign nationals as well.
No, because just for I wanted to make sure that anything not covered or anything they felt. So just to know, because that is why I said everything is tailor-made to your need. And God's grace, because I have also worked in 2-3 continents, so to an extent I have an idea also. So it's if no more questions, you can share my presentation to them, dear. So which has everything, and anything needed, feel free to get in touch. And as always, it's been a pleasure to be acquainted and have had the opportunity to present and interact also.
Thank you so much, ma'am. This has only been the second session for this batch. And as we move forward, we will, like we said, the iceberg, we will be looking into it more in depth, not just with relation to pain, but in relation to other common palliative care symptoms as well, which you will see later on is not just palliative care symptoms, but very commonly seen by specialists across the board. So with that note, I would like to thank you, ma'am, so much for taking time out from your busy schedule and giving such a concise, to the point presentation. Thank you so much, ma'am. And I would also like to thank all the participants from wherever you are. You have taken time out to join the session.
Thank you, one and all. Thank you to one and all.
Thank you, Dr. Radha, for joining us. I know that personally I have been pestering you from yesterday. Even though there was a difference in time zone, I addressed you good morning, and you are so kind enough to respond to my messages at those odd hours. Thank you so much for that. And thank you so much for your valuable time right now for this wonderful cohort. I believe that everyone has got a very good base foundation for the introduction of pain by this session. And we, of course, as promised, will be moving on with more vast topics, more different topics, more interesting conversations. So with that note, before signing off, happy Doctor's Day to everyone out there. Keep rocking.
Thank you. Thank you.
That note, this is Sri Priya along with Dr. Radha and Dr. Deepak signing off from the Tips Eco Hub. See you in the next session with another eminent faculty. Till then, everyone, stay safe, spread happiness. Take care. Bye-bye.